is Dr. Sara. Dr. Sara Yasin is an ST1 histopathology at University College London Hospitals and at NHS UK. Her case is entitled A Tale of Two Tissues, Unveiling a Pathological Puzzle, under supervision of Dr. Nasreen Magdi, consultant pathologist at University College London Hospitals, UK. Dr. Sara, I can see your screen and you may start.
Okay. Can you hear me clearly?
Yes, Doctor, I can hear you.
Okay. Thanks for this invitation. I'm Sara, specialty registrar at UCLH, and I'm going to present this case. Hopefully, will provide some interesting learning points. And let's start. Okay. In terms of the clinical background, the specimen comes from 16 years old, male with a history of bilateral undescended testis, laparoscopic orchidopexy of the left testis. However, the right testis left intra-abdominally for 15 years. Other clinical features: premature adrenarche, poor testosterone response, rudimentary Mullerian structures. And what we received: right orchidectomy with a spermatocord and intact tonica. And on slicing, we found a homogeneous whitish tiny mass with a maximum diameter of 8 millimeters. And on histology, this is the first slide. We can see on the right side picture, this is structure, which I'm pointing to. It's epididymis structure, which is totally normal. However, on this age, we can see this looks different. It looks like a fallopian tube. And by higher power on the right side, we can see the ciliated columnar epithelium of fallopian tube, which in keeping with the background of persistent Mullerian structure. And this is the second slide by a low power. We can see well-circumscribed tumor seen macroscopically as a nodule, with the background of testicular tissue comprising seminiferous tubule. And this is a slide for the tumor as well. As I have mentioned, it's well-circumscribed nodule, and we can see Zeus tubular structure. Sorry. And at this stage raises the possibility of Sertoli cell tumor maybe. And this is the tumor and background again. And this is the background. And what we can see here by high power, we can see seminiferous tubule lined by immature Sertoli cells and primitive germ cells without spermatogonia. But within the seminiferous tubule, we can see those atypical cells with clear cytoplasm, prominent nucleoli, large angulated nucleus, and coarse chromatin, and typically at the niche of spermatogonia. It could be germ cell neoplasia in situ, but reliable diagnosis for this case should be done by immunohistochemistry, which we will go through in a second. And our differential diagnosis now, it could be Sertoli cell tumor, it could be other 6-cord stromal tumors with background of GC&IS. And immunohistochemistry we will do for 6-cord stromal tumor inhibin, CD99 beta-catenin. And for GC&IS we will do OCT3 PLAB CD117. And here, this is inhibin staining. Tumor cells show diffuse positive staining for inhibin. However, to be aware, in the background, it stains the background as we have immature Sertoli cells in the seminiferous tubule and scattered Leydig-like cells in gonadal stroma, which is normally stained for inhibin as well. And we can see tumor cells shows positive membranous staining for CD99 as well. But when we did PLAB to confirm GNIS in the background, which is stained for PLAB, however, we can see those atypical germ cells in the tumor, which is stained positive for PLAB as well. And this is another picture. So is it mixed germ cell and 6-cord tumor? So let's have a look again on the slides. And this is the tumor with a higher power. And actually, we can see two cell population. And looking by a higher power, we can see this red arrow. Sorry. Okay. This red arrows shows small sex-cord cells forming palisades at the periphery of nests and rosettes around the basement membrane. And the blue one shows large atypical cells like those we saw in GCNIS, which are atypical germ cells. And let's back again to this is a slide for the tumor, and let's try to describe again. We can see by high power nests and cords of germ cells, small sex-cord cells, and globoid deposits of hyaline basement membrane. The germ cells have large nuclei, prominent nuclei, and pale to clear cytoplasm with frequent mitotic figure. And including abnormal forms, and are scattered between the sex-cord cells, forming palisades at the periphery of nests and rosettes around the basement membrane. And we have this slide showing few laminated calcification within the tumor as well. And immunohistochemistry for germ cell component show positive PLAB staining OCT3/4, while the other component is seen negative. And for the sex-cord cells, show positive staining for inhibin and CD99. And the question here, did WHO classification tackle this mixed tumor entity? And the answer is yes. So WHO classification has always identified an entity of mixed germ cell tumor and stromal tumor in 2004, 2016. And there was a separate entity of mixed tumor, which is gonadoblastoma. However, the huge jump was in the latest version in 2022 classification, where gonadoblastoma was identified as one of the germ cell tumor derived from germ cell neoplasia in situ. And our final diagnosis is gonadoblastoma, and by definition, it's in situ form of malignant germ cell tumor consisting of germ cell neoplasia in situ, seminoma or this germinoma cells, and incompletely differentiated sex-cord cells. And it is stated as PTIS, as I have mentioned, is non-invasive and in situ tumor. And regarding the prognosis and prediction for this case, given the potential of gonadoblastoma, it can transform into an invasive germ cell tumor. Gonadectomy is recommended in all cases. And fortunately, surgical excision and bilateral gonadectomy result in cure of the tumor and the prevention of contralateral gonadoblastoma. However, in cases if there is like invasive tumor, staging and prognosis will vary accordingly. If we try to conclude the take-home message for this case, I think it would be, when reporting GCNIS and gonadoblastoma in a single gonad, this is indicating differences in sex development. And to be aware what is DSD, it's atypical gonadal development that result in genital ambiguity of variable degree ranging from almost female phenotype to almost male phenotype with normal peripheral karyotyping of 46XY. And particularly for this case, it was clinically in keeping with 46XY partial gonadal degenesis, which is incomplete testis determination in individual with a normal male karyotype with presence of Müllerian structure. Thank you.